In this segment, we're going to discuss some of the recent preclinical mouse DIO results from a study where we were testing the dose-dependent effect of nimacimab. And we were doing this by bookending it as a comparator to monlunabant at an active, clinically translatable dose as well. The study is broken into two parts, with the initial aspect, the so-called phase A, looking at the magnitude of weight loss and other biomarker readouts, while the second component of the study was after drug withdrawal, and this is the so-called rebound phase of the study. When looking at the doses selected for this study, we chose the doses based on exposure across periods of active weight loss, and we translate those to our clinic using the same metric, that is area under the curve analysis, that is exposure over active periods of weight loss. And we see that we are looking at a very similar dose. That is bookended by 75 mg per kg every 3 days in our DIO model, being very similar to our current phase 2 clinical dose, potentially slightly lower, with our 240 mg per kg every 3-day dose in the DIO model being slightly higher than our current clinical phase 2 dose. However, when we use a compartment analysis, which we also think is very valid and an interesting approach to looking at exposure, that is distribution in a particular compartment, such as the adipose, liver, etc. These peripheral compartments we think are quite important. And the 240 mg per kg nimacimab dose in the DIO model is on the upper end of our human phase 2 clinical dose. However, this dose is very much in line with our clinical dose when looking at it through a compartmental analysis, that is the distribution within the adipose tissue. We also looked at a much higher dose of nimacimab, the 750 mg per kg dose. And this is really to test the pathway itself, looking at how nimacimab can inhibit CB1 at a sort of maximal dose, which will allow us to understand not only the pathway, but even help us with some internal CMC and development approaches that we're looking at currently. The monlunabant dose at 3 mg per kg daily is in line with the phase 2 monlunabant dose that was reported recently. This dose is just slightly higher than the 20 mg per kg phase 2 dose. So a very active dose of monlunabant. So looking at the phase A, that is the efficacy treatment of these therapeutics, I would draw your attention to the 3 nimacimab curves. That's the 75, the 240, and the 750 mg per kg every 3-day dose. You can see a clear dose-dependent response, particularly notable over the first 15 to 20 days. And this is evident while looking at absolute weight, that's body weight in grams, or looking at this as a percent change from baseline. Both patterns are very similar. Ultimately, we do see that the 75 and 240 doses are really getting close to converging at day 24. And this is just before the end of the phase A, the efficacy phase, before we move into the rebound phase, which we'll talk about shortly. So we see close to a 19-20% weight loss with the nimacimab at these doses. When we look at the high dose, we can see all the way up to a 27% weight loss with the 750 mg per kg, speaking to really maximizing this pathway. Very interesting, looking deeper into how mechanistically we think this is occurring. And some of the biomarker data will be informing us of that, and that data is still ongoing. The analysis of that data is happening now, so we can't speak too much to that, but just noting the potential of nimacimab at these doses. Now, the other piece I'd like to highlight here is monlunabant. Very interesting that in the green squares, we see that monlunabant is able to drive weight loss early. And this, we think, is likely driven through the small molecule approach and the potential for engagement early on in the central compartment. We do see, however, that At about 12 days, there's a sort of flattening of the monlunabant therapeutic in terms of the weight loss curve. And ultimately, this therapeutic comes in slightly less efficacious than either dose of the lower doses of nimacimab, ending up at about 17% on day 24. So different curves for sure, and maybe an earlier flattening of the weight loss curve with monlunabant. Now, as we move into the withdrawal phase, so drug is withdrawn, and we can look at what the curves do over this segment. Now, before I show you that, I just want to discuss that we're seeing a very interesting pattern, which has been very reproducible, frankly, and that is in terms of body composition, fat mass being the driver of weight loss with lean mass preservation. This occurs across all of the CB1 therapeutics, monlunabant included. We see a significant weight loss. However, we do note that nimacimab 750 milligram dose does have a significant reduction in fat mass relative to monlunabant, not the other lower doses of nimacimab. The other piece I would draw your attention to is the reduction in daily food intake. Now, notably, we see a very sharp decline in both monlunabant and in the higher dose of nimacimab. This, however, sort of switches as that phase A moves along, and ultimately we see a very similar caloric intake across all the doses towards the end of this phase A period. But these are all fairly close, and I would argue that the food intake really was driven off particularly with monlunabant, was driven off that early phase. All of these CB1 therapeutics have a very similar profile globally through phase A. Now, moving into the withdrawal phase, we can see there's a distinct pattern in terms of the magnitude and kinetics of rebound, with monlunabant sharply increasing in terms of the weight gain that occurs. All doses of nimacimab are able to maintain a relatively flat level of weight loss. There's a slight increase over the 24 days that the mice were not treated, and this is again the withdrawal phase, so no dosing at all of any therapeutic. And just to put this into context, this 24 days is roughly 100 weeks in humans. So this is a very relatively long period to maintain this type of weight loss. So very distinct with the small molecule based approach relative to our nimacimab data set. And we've seen this consistently now over multiple studies. This type of blunted rebound is quite striking, and we're certainly looking deeper into it. We do believe that energy expenditure has been reported widely with CB1. We see that in our models as well. We're definitely exploring that, as well as eliminating the potential for a PK/PD elongation. We do believe that this drug clears very quickly. We have evidence that that's happening, so we don't believe that this is simply the presence of elongated PK dynamics. In fact, the lipid metabolism, some of the pillars that we discuss are likely at play here and allow for this type of preferential maintenance of weight loss. Additionally, when looking at this rebound phase using an echo MRI endpoint, we can look at the relative shift in both fat mass and lean mass in the different groups. So when we look at in the blue box, that represents the rebound phase, you can see that both the lean mass and the fat mass remain relatively stable for all nimacimab groups. However, it's worth noting that monlunabant does see a shift in the fat mass compartment, with fat mass actually increasing over this rebound period. So we're seeing that this shift is driven by an increase in fat mass, and this, of course, is not a productive shift in terms of how that might translate to the clinic. And lastly, when we look at the rebound phase as it relates to food intake, it's striking that there's not a huge shift in any of the groups in terms of the daily food intake, suggesting that there's other mechanisms at play rather than simply, for example, the monlunabant group just taking in more food to explain this notable sharp increase in rebound. So this again speaks to other drivers, other mechanisms, notably energy expenditure, lipid metabolism, et cetera, helping to explain this relative stable rebound phase with nimacimab that does not exist and is not present with monlunabant. Collectively, we're very excited about this dose titration monlunabant comparator study. There's still ongoing work related to all the different biomarker. We have samples coming at this switch from the phase A to phase B. We have tissues and serum samples both at pre-study as well as end of study, and all that is underway. And we'll be using these tissues and serum samples to really understand mechanisms that were detailed in our 4 pillars comments. So those mechanisms will be analyzed as it relates to this study, and we look forward to sharing that data as soon as we have it.